Welcome to the webinar. You have entered as an attendee in listen-only mode.
Hello, and welcome to the webinar. I'm Dr. David Nace, Chief Medical Officer at Innovactor, and I'm so pleased to have you all join us for this first webinar of the year, Healthcare 2021. Oh gosh, good riddance to 2020. New strategies for a new decade. So let's get into it. Lots to talk about. I want to actually welcome our two very esteemed panelists. So let's do that right now. So first of all, we have Jonathan Bush. Many of you know him as the former CEO and co-founder of Telehealth, and he's currently the executive chairman at Firefly Health. Jonathan, great to have you on board.
Well, it is a treat to be here, as always, Dr. Nace.
Super. And then joining Jonathan is Deepak Goyal, who's a partner at PricewaterhouseCoopers and deeply involved with healthcare for many, many years. Deepak, welcome.
Thank you, Dr. Nace. Thanks for having me and looking forward to the discussion.
We've got so much to talk about, gentlemen. So let's start off thinking about before the pandemic. You know, there was lots of talk about moving to value-based care, moving away from fee-for-service, probably for the past 15 years, it seems. Jonathan, what's been the barrier?
Oh, well, obviously, when you, in my experience, when you succeed, you grow. One of the many things you grow is your own vulnerabilities. You end up with flank that you need to protect. And obviously, we've developed in this country some of the great hospital systems and medical groups. And these guys eventually develop flank they need to protect. They develop asset bases and salary expectations that they need to protect, and virtualization eats away at them, whereas a pandemic makes you get over your petty concerns about your flank and get on with life. And I think that kind of shook us out of our tendency to homeostasis.
You know, I think, Deepak, the pandemic, I think, as Jonathan pointed out, it really took us all by surprise. From your view at PricewaterhouseCoopers, you know, how did you see that surprise really hit us? You know, were we prepared? And if not, what were the big issues that we began to experience?
Yeah, Dr. Nace, I would say I don't think we were prepared at all. I think, you know, from working with a number of health systems that I do, I think everybody had to scramble. We were missing some core elements of capabilities that we, you know, ultimately needed to respond to this, right? We needed a good view of our consumers. We needed a good way to engage with our consumers, to drive communication, to drive targeted outreach. We needed to pivot our workforce, right? You know, we had to pivot, you know, as we canceled our elective procedures and so on. We had to redeploy the workforce to support testing, to support vaccine administration and other activities related to COVID response. And I would say most health systems were not very well prepared. Even now, I would argue that, you know, most health systems, you know, although we have made progress, I think we had, you know, COVID has led to a lot of innovations in terms of establishing some of those foundational capabilities that I talked about. But we have a lot of maturing of those capabilities to do to continue to be prepared for these kind of events in the future.
Would you, Deepak, though, say that while we weren't prepared, we were pretty resilient? I was very, particularly on the clinical side, like we were over-intubating people, we were using protocols that didn't match the disease, and the sharing and learning and the speed of evolution, I felt, given our lack of, I mean, certainly weren't rehearsing for this, and any federal rehearsing that was planned by previous wonderful presidents was not used. But I was so impressed by the resiliency and the speed with which, but I don't know if you, maybe I was at a gauzy enough distance.
No, I would agree, Jonathan. I think the resilience was tremendous. And I would say, you know, both from a health systems perspective, right? You know, we, you know, pulled out all the stops. We invested in those capabilities. We invested in our workforce, but also from a regulatory perspective, right? So there were some pretty significant regulatory advancements that were made during the time of COVID, which ultimately allowed us to, frankly, respond better, right? So a lot of the regulations that came out around virtual care reimbursement, licensure requirements, and things like that, those things helped us a lot, right? And I think, like I mentioned earlier, I think we are now at a point where I think we are definitely better prepared. Okay, as we look to the future, we just have to think about, what do we do with the capabilities that we stood up in a hurry during the time of COVID, and how do we continue to optimize? So really, that becomes a very strategic foundation for us going forward in terms of driving digital transformation, right? So I think those are the crossroads that we are at right now.
Yeah, and I think that digital transformation is kind of what we want to get into. And COVID may have highlighted some of the great, long-standing vulnerabilities or fragility in our healthcare system. Let's break this down a little bit. I think the pandemic really began to have health systems in particular, as well as payers, realize they don't have real-time predictive information about both caring for patients and their business overall. Jonathan, why do you think that's been? What's been the underlying driver?
Oh, as we said earlier, our success, the success of the major players has been sort of centered on the edifice, centered on the kind of centers of excellence and the buildings and the kind of miraculous things you can do at the sort of tertiary tip of the pyramid. And anything that interrupts, traffic at the tip of the pyramid is considered kind of a pain. And when you get to a pandemic, you need the opposite. You need to be able to see all the way out to the hinterlands. And, this is a world-class case study for population health, right? I mean, it's the mother lode of population health. And that orientation has not been the way you prosper as a health system historically. I think every PowerPoint we've seen for the last, since Obama won, has been that, we should probably be good at this. But economically and clinically, it certainly hasn't more economically, it hasn't mattered until we got to this. And now, we might be joining the rest of the world where CRM is incredibly valuable, and understanding relationships and developing them, whether they're buying in the moment or not, or in this case, using hospital beds in the moment or not, becomes an actual business benefit in medicine.
Yeah, Jonathan, I think that's very nicely said. I do agree. Because historically, we have always been focused on this heads in beds type of focus. Very focused on
and rightly so. If you're the CFO,
yeah, and that's rightly so. I mean, that's the primary way for you to.
Who cares if you get only 85% as much money on a readmission? That's 85% more than no readmission. If you think about it.
Absolutely. And I think COVID forced us to kind of think about capabilities which are more consumer centric, right? So not only thinking about the care setting, but also, establishing an ecosystem of capabilities, whether it's CRM, whether it's analytics, whether it's consumer 360, right? To really develop a deeper level of understanding of the consumer and using that information to drive that outreach and engagement in a very meaningful way. Okay. One thing I would say though is I know we talk about predictive capabilities. Okay. I remember a conversation early on in the COVID days back in March, April timeframe. One of the CIOs of a very large health system told me that, hey, forget about predictive. I don't have the ability today to have a report or dashboard that tells me how many COVID patients I'm taking care of in my health system. Right. So we had those kinds of issues in terms of, data, data quality, reporting, just the fragmentation of systems. And I think COVID forced us to, better mature those capabilities and establish some foundational elements in place. Yeah.
It sounds like the issue of fragmented data really has played a role in that. Now, you mentioned that, 360-degree view. I think both of you mentioned the issue of, having, I forget predictive, I need real time, like what's going on today. I need a picture. Why have we had and struggled with such fragmented data stores?
Honestly, I don't think it's been, it's all been acknowledged as important, but it's never been urgent. It's never been, oh, we have an ACO and, the classic cocktail line, we have 85% of our contracts are now, risk-based or value-based. And what they mean is, if everything goes to hell in a handbasket, we may lose 1% of our revenue, so it sort of counts, but doesn't matter. All of a sudden, you could literally be wiped out as a hospital and on deferral if you don't have a good eye on, what your sort of membership, your likely catchment group is going to do. And I think that moved it from important but not urgent to urgent and important. And I think once we get out of our old homeostasis and realize we can do well in the new one, we're seeing lots of adoption. Deepak before, as we were prepping, was talking about, entire hospital companies that are getting started with no buildings. Just drive the hospital to the house. There's lots and lots and lots of sort of potential energy that's been in PowerPoint for years that is slowly moving I should say more quickly now, thanks to moving to kinetic energy, moving to action.
Yeah, and I think it's also a little bit of a function of where we have been in terms of the maturity of our technology infrastructure within healthcare, right? And if you look at even the maturity of the large EHR vendors, like over time, they have added more solutions, more service lines, and so on. So a lot of health systems, especially the large ones, have this broad set of applications. Some of those are point solutions and so on. And when you have so many applications in infrastructure, it's very hard for you to really make sense of data, right? And to your point, Jonathan, we as an industry had also not invested as much in data quality, data governance, and so on to really give us the insight that we needed, right? So the data quality in healthcare has been broken, right? And it's not been very good, right? And I think we are with the progression of the technology infrastructure, more seamless applications, we are starting to realize that vision now, where we have more control on data quality. We are able to institute data governance policies, which we were not able to do before, which will all lead to better analytics, better outcomes and quality and such.
So you make a good point on the tech. I one of the many very good reasons why I got fired from Athena was the amount of money I was spending trying to refactor the clinical data and the stack at Athena to deal with the fact that when we tried to deal with non-Athena data, the rules engine worked well, the scrubbers worked well. The problem is everything got scrubbed out because nothing was harmonized, because it had never been used in concert before. And one of the things that got me very inspired, sorry, plug your ears if you don't like fierce plugging, but what I loved about Innovaceur was the amount of not the tech, but the architecture and the cleaning that went into using the data that made it actually, grease the skids so that it would actually, multi-owned, multi-tenant data could be actually usable on either side of a pipe. When I had failed at trying to put that toothpaste back in the tube and get it to come out integrated previously. I would also add, and this is too long, I'm sorry, in addition to tech and business model, which we've talked about, we should probably point out regulatory, which also has had a couple of big leaps, one related to COVID and one related to the Cures Act.
So lots of people are trying to integrate their data. People are using virtual care. Many of us have been on Zoom calls all day long and getting care in our homes. So lots of things that we've talked about are starting to be addressed, and that's really awesome. Let's just do a quick check-in with our audience and see how their organization is currently thinking about how to provide more seamless care in the current environment. So if you could all go to the chat box where you can answer this poll. Please select one of the following, the most important. Are you working to enhance patient-clinician relationships, offer a better digital experience for patients, improve accessibility to services and the staff themselves, offer ongoing patient outreach and engagement, or enabling support from the community? community healthcare services, as we all focus more on thinking about the socioeconomic and environmental issues. So, gentlemen, while we're waiting for our audience, our 600 plus people on this webinar to answer this, Paul, one of the questions that came up is that given the pandemic, we're seeing a lot of mental health issues come up. Deepak, what's been your visibility about the issue of mental health in the current pandemic era?
Dr. Ness, I have been seeing the same. I think mental health issues, whether it's related to your patients or even your own workforce, have been very prevalent, and they're coming up quite a bit. I think the good thing is as a result of some of the regulatory requirements that came out a couple of years ago around parity and so on. I think we have made some progress in terms of supporting mental health patients. I would also say that virtual health has actually helped quite a bit, right? So I'm seeing a number of my clients and health systems that I work with, leveraging virtual health to deliver services to those mental health patients, whether they're dealing with depression or anxiety and so on. I think there is also investment that is being made in some wellness type of tools that allow consumers to manage their mental health on their own, right? So the number of apps, as you've seen, that are available. Our own company, PwC that I work with, we have made investments to make some of those types of tools available to the workforce, which has gone very far in terms of combating some of those mental health issues during the time of COVID, when we are all locked up and our lifestyles are completely disrupted. Jonathan, I don't know what you are seeing, if you are seeing something similar from your experience.
Yes, no, absolutely. In fact, at Firefly, where we're sort of fully at risk for the whole life, it's kind of a virtual health system. We had a 4x increase in named mental health care over the course of COVID, with sort of specific diagnosis around anxiety and depression. But in addition to that, if you analyze real sort of root cause of utilization across the board, we've talked about this pre-COVID, kind of 80, if you think of behavioral determinants, right? Behavior-driven health, that's 80% of spend. And what is that but mental health, right? If you think about diabetes, I mean, all of the behavior change you need to do to manage that well or get back out of it if it's a type that you can reverse, heart disease, all these things where we're eating, not sleeping, and then eating, smoking, drinking. These things are fundamentally mental health challenges. And so I think it's even bigger. And again, it's one of these wonderful things where COVID kind of shook what we've known in PowerPoint and talked about at cocktail sort of conferences for years and made us do something, moved our center of real kinetic energy over a little towards what we really should be doing.
Now, these are great thoughts. I see our poll is done. Let's go ahead and pull the poll results up and see what the audience thought about these issues. Interesting, pretty much across the board. Jonathan, curious why you see less focus on community health services and enhancing the relationships between doctors and the patient.
I don't know. Honestly, I can't tell. It's sort of like, which reason do you want to give for needing to virtualize your care center? Well, it would be better for relationships if you could, without massive overhead and coding and billing, talk to your patients for 5 minutes a week. It also would be necessary to do that through a digital experience. I mean, I think people were trying to answer, pick their favorite reason why, but I think if this poll said build more buildings, build a virtual care plan, do more procedures, do more behavioral support outreach, I think you'd see a much more spiked graph.
I think you're right, and it's one of the questions that came up, and we can pull the poll down. Is how how do we overcome the fact that there's a rate limiting step of so few licensed clinicians and the need to go to a healthcare system? So I think that's absolutely right. Strong focus on virtual care and just trying to deliver services.
Yeah, there is so much more profit potential per provider if you literally eliminate all of their coding and unnecessary care and replace it with just actual care. You could do so many. If you sort of, I'm sure Deepak's done this a million times, with operations optimization, like all the steps in the diagram and the behavior diagram and the workflow diagram of delivering care, when in fact the core of the care value is some sort of intimate conversation, some sort of bond and a check-in between a person with, let's say, diabetes and a doctor. If you took all those steps out and just they had an app, that's just got to happen. That's just gonna happen in the next 5 to 10 years. And I think if established players don't get on board, others will be happy to take their business from them.
Yeah, I think the other observation, Dr. Nace, I would agree with John. I think to some extent, I think what you see here is the function of the poll. I think from a digital experience perspective, I have seen a couple of things which I think have really spiked during the time of COVID, right? So one, there has been a need around establishing a digital front door, which has suddenly become paramount, right? It's establishing a clear channel, single channel for consumers to avail all of the healthcare services, whether they're just around, in getting information or scheduling an appointment or doing self-triaging and things like that, right? So one is that. Second, I would say, this whole concept of engagement and outreach, which is ultimately built on the foundation of digital marketing and CRM type of capabilities, right? That's something that has been lacking in healthcare, right? A lot of our, other industries, like retail, financial services, and so on, have actually mastered the art of digital marketing, right? And in healthcare, we were so far behind every other industry, and that's a critical capability that we needed to have, right? So I think there's a lot of focus on that, and I think those two things have been, very critical in our response to COVID. So I think it's more of that we have to invest in those. That's driving that prioritization versus saying that community services are, of course, just as important, right? So
what's the difference with other industries? It seems to me when I think about my experience with other healthcare, non-healthcare systems, they seem to be better using data and giving service to the consumer. As people start thinking about, do I move to the cloud? Do I think about leveraging, data in a different way? What do you think the possibilities are for how we might actually transform healthcare using data? Jonathan?
I mean, geez, once you get it clean, once you get some kind of unified data model where you're using data from different sources, the possibilities are, just vast, endless. It's just getting that rusty wheel turning the first time. That's hard. The other thing that's hard, of course, is that a lot of the kind of good AWACS overflight data we've got is claims-based, and so there's a skew to it. But that's fixable, or at least you can put a filter on your lens to adjust for it. But I think once you get it running, the possibilities are endless. And I think they represent major opportunities for local brands to become regional ones and regional ones to become national ones. We've all talked to members of fancy hospitals that say they're a national or a globally recognized institution. And we all know that 93% of their patient visits are from 20 miles away or less. And they really could become national institutions if this data problem were unlocked.
Yeah, and I would say I think that number of use cases, that it's tremendous opportunity, right? So I think in the industry we talk a lot about the clinical use of data, right? In terms of predicting risk, determining care interventions, and things like that. There is, of course, a lot of focus on that, right? Beyond that, I would argue that when it comes to financial, operational, and your broader population health objectives, a significant number of use cases that we don't always invest in as much. And I think to some extent you could argue that our core EHR systems should help us with financial and operational and even population health related data and analytics capabilities, but those applications, EHRs, fall way short of what we need. Right? I'll give you an example. As we know, access is the big problem in healthcare. Right? Being able to get consumers in a timely manner and so on. I have yet to see, most health systems do that well. Right? They're not able to really run the analytics out of the EHR system that tells them the demand side of the equation and the supply side of the equation in terms of the physician capacity and so on. And they're not able to do that analytics and create that demand and supply match, right? And that's a big problem, right? Same thing can be said for referral management, being able to predict the performance of your value contracts and things like that are fundamentally lacking, right? So, of course, there are a number of clinical use cases, but we should not, lose sight of some of these other dimensions as well, which are just as important.
Jonathan, as we learn from the pandemic, many people are now getting virtual care services, right? Even I can speak for my own experience. I saw a dermatologist in virtual care. I saw my primary care virtual care. I actually had some back pain, had physical therapy, and they come meet with me in my home virtual care. We have a lot of people from the audience chipping in. One person said they had cataract surgery on both eyes, one pre-COVID, one post-COVID. The post-COVID experience was much faster, much more efficient. They felt very comfortable. And they said, well, are we going to go back? Because it was much less costly as well. So with what we've learned, do you think after the pandemic passes, we'll see a return to the way things used to be done?
Well, I think this is the big question, right? That really, there is no clinical reason. There's obviously a business. Everyone would like to see their visits up. And so really it's a function of, will the new entrants and the early converts create enough market share pressure that everybody says, geez, I better keep doing it this way and do it better. We're all waiting to see. Certainly, I mean, my money is on that model. Firefly has been so much fun to watch. Started as virtual primary care, then they added behavioral health, then they added dermatology. Now they've added diabetes care, and 3 or 4 cancers. And in each of these cases, they've got a small number of specialists that are serving them nationwide. So instead of being 1% of 100 oncologists' dance card, they get to be 100% of one, or 50% of one oncologist's dance card. So you get unbelievable bonding and coordination when you can do that much volume with someone across the country. Benefit for the specialist, much more pathology targeted narrowly at what she's good at, what is her favorite. There are just so many good reasons for expanding the geographic catchment of care by virtualizing. It's just a question of whether the fee-for-service, world versus the sort of membership / at-risk, full risk world, gets the upper hand. But I'm actually betting that premiums are high enough that starting with the sort of middle class commercially insureds, that they're going to pivot and you're going to see all the mainstream players need to virtualize their offerings and do it hard.
I think, Deepak, I heard mentioned actually from both of you in the past about CRM and using CRM in healthcare. And that might relate to targeting and engaging patients with different strategies. Can we talk a little bit more about that? Because I think for many people, they don't know what CRM is and how it might be applied.
Customer relationship management. If you think about it, what is Pop Health? Everyone does Pop Health, but they do it off in the corner with their, chief quality officer or their little, don't get mad at me, Obama, look, I have ACOs kind of department. And really all it is knowing your customer, being really accessible, to your customer, and you shouldn't. I don't think mathematically it will work out that it's only profitable to you when you have an ACO to be really engaged with your potential customers, right? With your most likely buyers. That everybody within 100 miles of your hospital have an account, get updates, maybe get either subscription or free advice, and be super instantly accessible with the right chart and the right data, maybe through an app or whatever, when they need care. Yeah, don't put that in the quality department, put that in the central nervous system department. I'm seeing that happening.
Yeah, I would define the CRM a little bit more, and hopefully that will also help the audience, right? So first of all, I typically see CRM systems serving the function of marketing, sales, and service within healthcare organizations, right? And there's some core tenets of the CRM platforms that are very important for us to understand within that, right? So there is as Jonathan mentioned, knowing the customer, right? A lot of health systems have this objective of know me, right? Which is they want to establish the customer 360 and so on. That could be part of the CRM, although there are other strategies you could also take where you could have a customer 360 that resides outside of CRM but feeds into the CRM, right? There's a customer 360 dimension. Second capability, just in general, these CRM platforms tend to be low code, no code type of platforms, right? Where you don't need heavy investment by IT to build custom code and things like that, right? They're more easily configurable. But they do allow you to have this, customer 360. They allow you to have a, very advanced kind of workflow management type of capabilities, right? So you can create more seamless handoffs for customers within the health system, right? And then they tend to have fairly advanced omni-channel capabilities, right? So you can respect customers' preferences and be able to engage with them on their preferred channel, right? So if you look at that definition, marketing, sales, and service, customer 360, workflow management, omni-channel, all of these things put together, right, really allow you to service the consumers differently and really allow you to respond to the consumers in the time of need, like COVID, in terms of engagement and outreach.
Yeah, and I think to Jonathan's point, with this concept of really virtualization, we might start thinking about how, particularly for chronic care patients, a team might be virtualized, right? Where they could work together and engage together in a virtual world.
Absolutely. Sure. Absolutely. I think the next evolution around virtualization is, I know COVID has forced us to, establish or drive kind of, more penetration of virtual health in general. I think the next evolution is, starting to have these virtual care pathways that we establish around specific disease conditions and, and so on, right? So, for example, I see a lot of examples emerging around digital care pathways that incorporate the elements of patient education, outreach, virtual health, even hospital at home type of capabilities in an end-to-end digital care pathway that is informed by data, but, put together in a journey for the consumer that you can enable in a very virtual manner, right? So I think those kinds of constructs are becoming more real now, recognized.
So I've now had several members of what is now 700 people in the audience speak to the issue of licensure. How when you're virtualizing, how about cross-state issues and licensure issues? Is that something that's been a barrier, and can we resolve that going into a post-pandemic world?
Yeah, that's a good chance to pivot over to the third leg of this stool, which is the regulatory. So you have two big movements, right? One is the temporary relief of state-specific licensure restrictions through the COVID, as well as other benefit changes that have been given extensions. And my sense is you're not putting the genie back in the bottle. We'll see. And the other is the Cures Act, which it's finally made it 4 years later through rulemaking that makes it basically highly unlikely that you're going to not share your data with other players. And I think those two things make it very likely that virtual players can use specialists and themselves in multiple states. There's also the British approach of in England they call specialist consultant physicians, and what they're technically providing their services to the GP who's got the patient relationship. And you can do that. That is done here in the United States, where a specialist will say, well, I'll help you, Dr. Nace. It's your patient. You've got to be licensed. You've got to write the prescriptions. But I'll talk to the patient and I'll look at their films and I'll give you guidance. And that, relieves that specialist from a lot of malpractice licensing requirements. It allows you to take that specialist's specialized knowledge national. So either through the COVID or through that, I'm expecting this to keep going.
So with a lot of these virtual care strategies, the CRM, the ability to bring in team members, we're talking about data underlying this digital transformation. So one of the things that the nomenclature that pops up is this concept of what is artificial intelligence, and how might that be really a potential game changer here for healthcare as we move to digital transformation. Jonathan, let's start with you. What is AI?
Well, obviously the ability to look at more things than a person can and come up with more scenarios than a person can. What you need, of course, for that is enough data that's harmonizable and readable for a machine to be even necessary. And frankly, despite the fact that many of us think we have a lot of data because we have 1 million records or 2 million records, you really need hundreds of millions of records and something to look for and decide to do against them for AI to be relevant. So again, as we get multi-system data sets, that possibility goes up. And it's anything from noticing who's about to crash in an ICU setting, doing easy reads in imaging, to getting better and better and better at, as Deepak was saying earlier, simple relationship management pathways for treating potential patients like current customers. All of those, the N of data points is potentially high enough that you could have a little machine leverage your decision-making and surveillance. And it could be the simplest thing as answering people's questions instantaneously with a bot rather than waiting for somebody in a call center queue 23 minutes.
Yeah, I would agree. I think just in terms of the technical kind of definition that you see around AI, right? There is, as Jonathan mentioned, being able to, drive or derive learnings or algorithms from vast amounts of data, right? We call that machine learning, right? Then there is the deep learning, which allows you to have these layered set of machine learning models that can feed into each other and have, solve very complex problems, right? There are a lot of applications for that in the industry. Being able to do what-if scenario analysis or simulation modeling, right? That has a lot of applications. Natural language processing, I also put in the bucket of AI, where you can, analyze unstructured data, the voice files. You can leverage NLP even in the context of your contact centers and things like that to determine consumer sentiment and so on. Intelligent process automation, and then I would say image analytics, as Jonathan mentioned, which is seeing a lot of applications in healthcare as it relates to providing supports to radiologists in terms of detecting diseases from your X-rays and so on, right? So very broad definition of AI. I think that number of applications of AI, not just in the clinical domain, which is I think very obvious. You also see pretty significant applications in the operational domains, and one big use case of AI that we also see is in the world of cyber or security, where you can leverage AI to to drive intrusion detection and being able to respond to threats and incidents. So broad set of use cases, Dr. Nace, and I think this AI is poised to continue to grow in healthcare, and we're going to see more adoption of this going forward.
Yeah, I want to underscore, Jonathan made the point about how the quality of the data and the completeness of the data is so important to have really effective AI. But you just drew a picture of where AI could help us in so many different ways. Jonathan, where do you think the future lies in terms of how AI may help us in terms of disease, health, and communities?
Well, I honestly think it's going to be a function of how willing probably the people on this webinar are to federalize their data, when they keep calling it precious and trying to keep people away from it. And they're like, well, I'm going to run IBM. I'm going to get Watson, and Watson's going to, let me cure cancer in my community hospital. I'm like, no, they're not. You need a lot more instances, a lot more variables over more time and more cases than any medical center on its own has. Any. And so if we get to more of a federated model with some commonality, better, joining, then you're going to see just all kinds of stuff. I also think, so first of all, everybody thinks that they've got their own little Watson account, open to Watson, which is, I'm sure, great. I don't know anything about it. You're wrong. You're not going to have AI alone. And second of all, I forgot what number 2 is, but I'm sure we'll be back before the webinar is over.
Well, let's check in with the audience and just ask another poll and kind of get a sense of, geez, with all this talk about technology, what is your top technology-enabled goal for 2021? Are you currently focused on enhancing using risk models, the rapid triage and risk assessment, using AI? Are you using telehealth service, this virtual care that we talked about across your enterprise, not just for select services like COVID? Are you looking at automating kind of a CRM perspective, right? Automating patient communication protocols and triggers using CRM and maybe some AI to look at different members, different patients, different outreaches that may be identifying their own behaviors and changing your communication strategy around that. Great use case for AI and CRM. And then are you looking at automating the actual pathway of care through your health system and automating the care coordination steps that your care coordinators are using? So this is tremendous, gentlemen, as we're waiting for this call. All of these different use cases post-COVID. And COVID's actually provided a bit of a silver lining, it seems. Jonathan, is that been your point of view?
Absolutely. I mean, and unfortunately, most great leaps came on the tail of great destruction. I mean, post-war Europe's boom, it's a bummer. We'll get better and better and better as a species of rejuvenating without destruction or threat of it. But certainly destructive episodes like this have always throughout history been rejuvenating. And that's certainly gone on here for sure. We'll see how much of it stays for how long.
Jonathan, I think we got most of that, but you're breaking up just a little bit.
Sorry.
That's okay. While you're working on that, Deepak, silver lining or not?
Yeah, no, absolutely. We have all heard that necessity is the mother of all invention, right? And I would say, that has been very true in this case, right? I think we have seen, progress worth 5 to 10 years of digital transformation happen over the course of 6 to 9 months through COVID, right? So I think it has definitely established, advanced our digital capabilities quite a bit. That's not to say we don't have a lot more work to do in the future, Dr. Nace. As I mentioned earlier, I think a lot of these capabilities that most health systems and payers built out, they were built in a hurry to respond to COVID, right? And to be able to manage patient risk, right? Now, I think the task that we have in front of us is, how do we optimize? How do we continue to build on this momentum that we have gained over the course of last 6 to 9 months and continue to drive more innovation in our industry?
Well, I see our poll results are done. Let's go ahead and bring them up, take a look, see what our audience had to say. Oh, just 1 second. Oh, this is interesting. Deepak, what do you think? Lots of focus on telehealth.
To be honest, it does not surprise me, right? So, as we were discussing earlier, I think telehealth is here to stay, right? There was a lot of kind of a relaxation of some of the reimbursement rules, licensure requirements, etc. that happened during COVID, and I think some of that is, much of that is here to stay. I would also say, through this experience, regulatory policies were also relaxed in terms of the use of advanced care practitioners and not just the physician in delivery of healthcare. And I think some of those policies are going to continue to stay. And then there are other regulations that are coming out, like hospital at home and things like that, which are all targeted towards significantly expanding the access to healthcare, right, and increasing the capacity of health system as a whole. And I think regulators as well as the payers and providers are starting to realize the value that offers in the long term, right, for the healthcare industry, but also, of course, for the consumers and patients that we serve, right? So I think the focus on telehealth is, absolutely important, and that's an area that we should continue to build on.
Yeah, and it's practical too, right? There's money there right now, and then you build on the other stuff as the business model migrates.
Right.
Absolutely. So let's start thinking about that post-pandemic world. And what may be an era of new partnerships. We started to see people share data, connect and communicate in different ways. Do we think that in addition to digital transformation, the digital transformation might allow for more collaboration and partnership between provider to provider, and payers and provider? Jonathan, you've been in the industry a long time thinking about this. What's your point of view here?
Well, I think obviously there's collaboration because these people are caring people in medicine, trying to help other people. That is enhanced when there is shared upside, when there's a business model that aligns with that. And it's whatever the opposite of enhanced. It's not good when there's a competitive dynamic. I'm watching the rise of these virtual and non-hospital accumulations of patients because I think they are sort of the Franciscan monks. They don't have a cathedral to fund or a winery to fund. I mean, they just have the lives. And if they play their cards right and don't get greedy, everybody who has diagnostics and operating rooms and specialists, will coordinate with these guys because they have the lives and they're not going to compete. They're not going to, they're just going to be buyers and sort of coordinators. Now, it's only a few percent now of all lives, but they're growing really fast and they're of size. So there's a point at which, even if they keep the same growth rate for 5 more years, they start to become 10, 15% of all commercial care. And then, a lot of them have already forked into Medicare. Some of them were born in Medicare. So I think as those, call them pay-viders, this pay-vider class rises, the need for the business model for coordination improves. And we've already talked about the tech platform being there and the regulatory environment being there.
Yeah, I think the tech platform is really, brought to need for the health system itself, a need to see real-time business information going back to that command center. But there's been a strong focus on also thinking about safety as people come back, not just for the employees, which have been at risk, but also for patients who want to return for elective surgeries, things like that. Deepak, what are some of the lessons learned that you've seen around collaboration and the use of data?
Yeah, so a couple of things. Just one point I wanted to just make around just the collaboration overall is I think we have to look at both the demand side and the supply side consideration that are ultimately driving this collaboration, right? So from a demand side perspective, right now think about what happened over the course of 9 months, right? So government had to issue a $3 trillion relief package. There is another $1.9 trillion relief package that's being contemplated right now. I think that's going to create a bit of a burden in terms of driving more value from healthcare in order for us to manage deficit, right? Think about the broader economy, right? So if we start to see some shrinkage in the industry, in the economy, right, employers and consumers are going to demand more value from healthcare, right? That's going to force, more kind of value-based care type of model or at-risk models as well, right? On the supply side, I would say, I think this experience that we just talked about in terms of new capabilities, new chassis that we have built around CRM, virtual health, data and analytics, give us a lot more confidence now that we can get there. Right? We have the ability to collaborate. We have the ability to drive digital transformation, and so on. And I think when both demand and supply side considerations and considerations are evolving, I think the scope for collaboration is pretty significant, right? So I'm very bullish on that posture. In terms of collaboration just within the workforce and the employees, I think that's absolutely paramount, right? Healthcare has responded in a tremendous way to COVID. We have put a lot of our workforce, in the front of the harm, right? And we are trying to manage that workforce in a way that we don't create risk for them, right? There is that risk. There is also the risk of burnout, right? So a lot of health systems are very heavily focused on figuring out, how to deal with that over long term, and also addressing some of those mental health type of considerations we talked about earlier to be able to manage the workforce better.
Well, there's a lot of comments coming in from the audience, very interesting about, I think we've addressed the issue about reverting around the state licensure issue that may continue, but also about the sharing of data. Is PHI a limitation? And then going back to data in general, a number of comments asking about EHRs, like, are they a barrier or are they potentially going to be helpful with the use of registries that they provide? Jonathan, lots of provocative things for you to comment on.
Why don't we go? We haven't really named EHR as a topic. And I think it's important. This is a good chance. Let me just shake off all my Athena PTSD here. But when we say EHR right now, it's kind of shorthand for a very specific thing, right? It is the workflow software oriented towards a visit or a procedure or an event, right?
Right.
Then it is the kind of data storage and compute, and it is the actual data architecture. We think of that whole thing as one thing. We actually don't even think of all the things that happen. We don't even think of the data on a patient as part of that. If hundreds of critical things are going on a patient somewhere else, nobody expects the EHR de facto to know that, right? So that full stack from front-end software to processing to data architecture to the actual stored data for one particular provider is being unbundled, right? So soon a health record will not refer to the workflow. So who cares what workflow software? Who cares what the workflow is? Could be a Fitbit, checking in. It could be, some diagnostic tests that are delivered from home. It could be an actual doctor's office visit using some company that we know of today as a purveyor of EHR. And all of that filters down to some record, right? There's a record that may have people filtering onto it from all kinds of different places. That migration hasn't happened yet, but a lot of what I'm seeing at Innovaccer, is the pre-work for that. The ability to scrub and make these data from multiple tenants actually mean the same thing. When I was at Athena, there were 92 and counting different lab-specific definitions for the word CBC. So give them a CBC. Okay, there's 92 different things that could actually mean when you get down to it. And that cleaning needs to go on before the word EHR ends up meaning not what we think it means, but what any patient, if you were to ask him on the street, thinks it would mean, which is the electronic record of me, right?
I think I want to pick up on that, Jonathan, because you're saying if you get the data out of the box, so to speak, the actual constructed architecture, begin to share it, start to apply these new techniques, get things into the cloud, harmonize the data, we really can start to move beyond the four walls, get better collaboration. And I think I just want to skip to this model that we think about here at Innovacer about how that data can be pulled together. And I think to your point before, if you're going to use good AI, you've got to have that data harmonized, use machine learning, and get a unified record, a unified view of the patient across all of these different systems. I think that's what you're sort of getting at, isn't it, Jonathan?
Yes, exactly. And you know, we talked about the 3 pillars here, right? You need a business model that people aren't afraid of it or don't think it would be bad for them. You need a tech stack that is unbundled, where the workflow of the office isn't the same piece of software, inseparable from the database for all care across all places, right? Which it is today. And then you need a regulatory environment that either doesn't stop it or maybe even sort of pushes it along. And if you look at those 3 tectonic plates, you know, enhanced by COVID, I think as they said in Flight of the Conchords Wednesday, conditions are perfect.
You know, Deepak, you've gotten to know our organization, Innovacer, for some time. We actually named the company Innovacer, meaning Innovation Accelerator. The idea that if you could get all the data and make it useful across all these different systems or boxes, and then also bring in other data about the social determinants of health from the community, social, environmental, combine the claims data from health systems, bring them all as a unified record, you could then open that data up for innovation. You could actually begin to use open APIs and build your own applications. So it really provides a nice view with the view of AI changing the world as to how we might actually start to really transform healthcare. Deepak, do you think this is a reality that we can move forward with?
Yeah, no, absolutely. So I would say, look, I think everything that we've talked about, everything Jonathan has mentioned around business model, around, you know, data aggregation. So I think that's absolutely true. I think, you know, few things that are happening that would make this get more traction in our healthcare environment. One, you know, I think the regulatory environment is easing up, right? There have also been some conversations, and CMS is going to issue a final rule around relaxing some of the requirements around start laws and anti-kickback laws and so on, which would enable more kind of data sharing, enablement, and partnership. Like number 2, I think Innovacer does a great job of aggregating the data, right? But typically, one of the big problems with data also is how do you activate the insight from the data, right? How do you make that insight available within the workflow of the clinicians, right? Which is a big problem in the industry from an analytics perspective, right? I think some of the innovation that you all are driving around that with InNote and other solutions that you offer, I think would make the use of analytics real. So, I'm very energized about the promise of your platform and the use cases that I'm seeing in the industry, and looking forward to how this evolves.
I think digital transformation is our future, and being able to innovate once we get data together and useful is going to really be the key. Gentlemen, I actually want to thank you as we get to the end of our webinar here. I integrated many of the questions, but I just want to say we had over 1,000 attendees in this interview. That's how much attraction the two of you have brought to this webinar. And also we had a highly participating group of people with our polls and asking questions. So I think with the 50 plus questions we've gotten, we couldn't get to them all. I just want to thank you all. We'll be in touch. We'll provide you with a copy of this stack. But this has been a great opportunity to talk about COVID, healthcare transformation, and the future of digital innovation. With that, gentlemen, thank you very much for joining.